One of the best exponents that we always make.
Assalamu alaikum.
Thanks, Anand. Just repeat.
I'm just trying to get the video to start recording, or get me the controls for that.
Okay.
IT people are working on that. Just give me a minute, I think.
Okay, no problem. I'll wait. It's just 4 o'clock now.
Assalamu alaikum. I think welcome everybody, and we'll let Dr. Bushra start the proceedings. I think the recording is going on.
Assalamu alaikum, everyone. Do you mind if you just turn on your pictures, like video, so that I can see people? It's more interactive if I can see. That would be good. Thank you. Okay, Bismillahirrahmanirrahim. So today we are going to talk about the ABCDE approach. I just want to ask if you had a chance to have a look at the information that I sent earlier. I think it's okay if you talk to me in between to keep the session more interactive. You can ask questions, you can involve and participate in the session, so that will make it more productive rather than just listening. So you can open your mics and just ask anything, and if I ask anything, then you can answer. So I can still not see many people, but anyway, let's start. So ABCD approach, I'm sure you have an idea about this ABCD approach, which is airway, breathing, circulation, disability, and exposure. So it's a very strong clinical tool for the initial assessment of any patient with any sick emergency patient that you can find, any acute medical or surgical emergencies. Because you don't need to have a definitive diagnosis to have a life-saving treatment. As you go along with this ABCD approach, you will find all the parameters that are needed to be treated. So you don't necessarily need to have a diagnosis prior to this before you approach. So if you start this approach in your daily life with seeing all patients, sorry,
I
especially the
think there is
sick
a lot
ones.
of bad, Bushra, I think there's a lot of bad connection.
Noise.
Maybe we should keep everybody mute, and anybody has
Okay.
any question, he can interrupt. They can interrupt.
Okay, then you turn your mic off. Then if I talk, okay, so turn your mics off then. So I was saying this ABCD approach, it helps you to find the seriousness of the condition and you prioritize treating them, because obviously people die with the airway problem first before they die with the B and C. So as you go along, and if you keep this methodical approach of looking after the patient from airway, breathing, circulation, then you keep on finding things, and it's very unlikely that you miss any major disaster or major problem. So first of all, when you see any patient, I think in this scenario, we will talk about somebody who is acutely unwell and has got slightly reduced GCS that would not be able to tell you what exactly is going on. So you start from your approach, and in this approach, if you keep this ABCD in mind, then you will see all the patients in this way. So from first of all, you look at the airway. First of all, you have to make sure that you are safe to approach, you are gloved and gowns on, because lately with COVID, lots of guidelines have changed. There's a bit of noise still. Lots of guidelines have changed because we should not go very close to the patient if in suspicion of COVID. So make sure that you have all the protective gear on you. You have the required team with you. But once you start approaching, then you look at the airway first. So for airway, you obviously start talking to the patients. You don't need to do anything before doing anything, asking patient that, are you okay, or hello. Then if they answer you, then it means that their airways are patent. So you move on to B. But before that, if they don't answer you, then you try and assess the patency of the airway. So there are lots of things which can obstruct the airway. You need to make sure that airway obstruction, how can you treat the airway obstruction? So can anyone tell me what could be the things that can cause airway obstruction? Rao?
Medical officers and SMOs first, please.
Yeah.
I am Rao Maz, and I would like to comment on this. In airway obstruction, many things can be there. If the patient is unconscious or has decreased GCS, so the tongue can fall back and cause obstruction. And similarly, there can be foreign bodies also. The choking is an example. And,
Yes. So there can be foreign body, there can be blood, there can be vomitus. So you try and look at it. If you see blood or vomitus, then you do the suction. So the aim is, as soon as you find a problem, you just solve it. You don't go forward until you solve the problem. So you do the suction, try and clear the airway. If there is a foreign body, it's not recommended to sweep from the mouth, because there is a risk of dislodging it even further. If it's really obvious, like dentures or something that you can pick up, then that's fine. But if it's a further bag, then if you put your finger in and try and get this out, there is a worry that you may dislodge them even further and cause further problems. So try not to do that, but try and do suction, try and clear their airway. So the other thing that obviously with the tongue fall, you try and lift their head up slightly, head tilt and chin lift. So this kind of maneuver makes the airway in align. If you think about the anatomy, then it makes your airway aligned. And see if there is any snoring, any stridor, anything that you can make better. If you are able to do so, then you apply the oxygen, 15 liters via non-rebreathe mask, or whatever the settings at your end. So you give the oxygen, and then if still you think that if you let them go, then you drop the airway, or you still hear the snoring sounds, then you need adjuncts. You need something to support, like a nasopharyngeal tube, then the oropharyngeal tube. So the whole idea is, until you are not happy to support the airway, that patient is now happy and breathing on their own, you don't move forward. So you have to treat airway problem first. So once you put the nasopharyngeal, so the book says if your patient is from GCS 8 to 15, then you try and put nasopharyngeal tube in. And I'm sure you must have done it, but there are some contraindications like head injury, then you may not have to insert, back of the throat to have the basal skull fracture. So don't do that in a suspicion of head injury. But nasopharyngeal injury, nasopharyngeal tube, if the patient does not tolerate that, it means they won't tolerate the oropharyngeal one, because oropharyngeal one is more tolerable for patients who are more unconscious, who cannot really look after their airway. So, take the size, measure the size from the angle of the mouth to the angle of the jaw, see the proper size, you turn it around and then sweep it in so that you may not push the tongue back. So airway is a very big station. If you want to talk about it, you can spend an hour about it, all about the adjuncts. But here we are just talking about the approach. So these things that you try and manage, secure the airway. Once you think that, yes, they are much more stable, put the oxygen on. And if they are not stable, if you think that they're still falling, even in the presence of oropharyngeal, nasopharyngeal, then you might need the bag mask valve. So if that is the case, then that means it's a temporary measure, the bag mask valve. You can do it for some time, but then that means the patient needs definitive airway. But you can buy time by using bag mask valve to secure time. And in the meantime, you can call the anesthetist or people who can intubate the patient, because you have now realized that this patient is not going to manage their own airway without major support. So for time being, you just head tilt, chin lift, put the adjuncts, put the oxygen on. Happy about the airway? Yeah. So this is only the airway assessment. So once you have done it, then you move on to B. Okay. So once you made sure that, yes, I'm happy with the airway. In real life, things happen simultaneously. You are not on your own doing all this stuff by yourself. So obviously you will have a couple of people with you, so you can delegate the task before the patient arrives or when they arrive, that, okay, you are going to look after the airway, you are going to do B, and XYZ person will be looking after C, and one person just stand back and look at the whole situation. We will talk about this when we will talk about more in the trauma session, which is going to be like a trauma leader, and how team working is done. But in real life, all things happen simultaneously, but people keep doing things, but obviously your priority is A. So once you have dealt with it, then you go on to B. So for B, you see if the patient is breathing spontaneously. You feel the approach of look, listen, and feel. So you look for chest movements. Is it expanding? You listen to their breath sounds, and you feel for their chest. Okay, so three parts of it. So you look for chest expansion. You look, if they are breathing, then what is the quality of their breathing? Are they shallow breaths? Are they deeper breaths, or the proper breathing? And then for that, you need to look at the numbers. So the numbers would be respiratory rate. You will look at the oxygen saturations. So if they are having with oxygen, if their saturations are 98% on 15 liters of oxygen, then that means that at the moment their breathing is effective, but obviously with the help of oxygen. So there is some compromise either because of the airway or there is some underlying issue. And then you talk about when you assess that, then you look at the chest expansion, you look at the respiratory rate. So if the respiratory rate is normal, like 18 to 20, and the saturations are 98%, you listen to the chest on both sides and you feel equal air entry. And then you feel the chest and you don't find any, tenderness or broken ribs or flail chest segment, then it means that patient is okay with B for now. Are you all happy with that? So when you talk about the trauma, then obviously we'll look at the chest deformity and then we'll do percussion and we'll do further things. But if you look, when you listen to the chest and if you find the air entry is reduced on one side and its saturations are a bit low and oxygen or the respiratory rate is a bit high, then you suspect that there is an underlying problem with B. So you need to sort out that problem, okay? So that, as I said, it happens simultaneously, but you have detected a problem in B. So they may have got an underlying infection. They may have got underlying pneumothorax. That's why their chest sounds are like that. So then is the clinical judgment of how things are going, that whether you need to treat it now or whether you have noticed it and you need some investigations to find it. Because in case of like tension pneumothorax, you cannot wait. You have to deal with the problem there and then before you move on to C. Okay, so if you, for example, found out a pneumothorax, then yes, you have realized the problem. Then you start preparing for either on-site chest X-ray, but if it's tension pneumothorax, you do the thoracocentesis and you plan for the chest tube, and somebody will be on the case before you go on to C. Once you do an intervention, for example, if you do a thoracocentesis with the needle or put a chest drain, after any intervention, you go back and reassess your patient. So you go back onto A. So the reassessment is very, very important because you never know while you are doing B or C, patient might have dropped their A. So you go back and reassess that whether this intervention has made any difference or nothing has changed. So if you do the thoracocentesis, okay, you go back onto airway and verbalize, yes, airway are still patent, they're still maintaining, the oxygen is on, and there is no noise or no further secretions in the mouth. And then coming on to B, has the chest drain made any difference? Have the SATs improved? Have the respiratory rate gone down? What about the chest expansion? So whatever you have done, you need to know that whether this has helped or not helped so that you can plan further. So if you don't find any problem with B and all the parameters are okay, then you move on to C. So until now, I think the main issues with if you miss anything in A or B, then the patient can die. And if you concentrate on C and D, then don't look on the A and B, then you will lose the opportunity to treat those immediate things that can be treated there and then. So coming on to C, like I said before, obviously somebody will be doing it already. So circulation, obviously you look for patient's color. How do they look? Are they sweaty, clammy, pale? What are the things going on? Have they got any obvious bleeding going on? Is there any blood on the floor? Is there any blood around them? Are they oozing out any blood from rectum or anywhere, like they have got long bone broken? They can have internal hemorrhage. So any blood loss, obviously you will look at the numbers. So you check for their blood pressure. What is the blood pressure doing? What is the pulse? When you feel the pulse, what's the character? What's the volume of the pulse? Is it weak pulse? Are they losing blood from somewhere? Or is it normal pulse or normal blood pressure? And then you look for long bone injuries if they have any, and you feel the abdomen. So even if patient is unconscious, you can still feel the rigidity of the abdomen. You can see the distension. You can see a pulsatile mass, feel for it. So there are lots of things that you can feel or palpate on the abdomen and at the same time feel for the pelvis, because internal bleeding can also kill the patient. So if your patient's blood pressure is low, they are tachycardic, their blood pressure is on the lower side, that means maybe the problem is C. So you need to figure out what is the C problem. They might need a CT scan to see what's going on inside the abdomen. Maybe there is a bleeding going on. So at the same time, you try and cannulate the patient in both sides, bigger cannula, start IV fluids, because you still need to get their resuscitation. So we're talking about saving life-threatening emergencies when you approach a very sick patient. So on C, when we put the cannula in, at the same time, you take all the bloods that you need, full blood count, UCNEs, LFTs, clotting, and the most important, which you can have on the bedside, is the blood gas. That is very important tool to see how sick is the patient, because you can get the result there and then. So you see their pH, you check their oxygen saturations, you check their hemoglobin, you can see on the blood gas, you can see their blood glucose on the gas, and you can see any acidosis or alkalosis which is going on. So you can find out if there is a problem with C. If you have figured out that, oh, they have got, bleeding going on, then you are ready to call the surgeons to get ready, because there is some bleeding going on somewhere. If you can't see, maybe it's internal or the C is not improving. So first they say that you first bag you give with the fluid. And then if you identified bleeding, then you start giving the blood, O negative blood. You start giving until they have got the cross match done ready for them. So two IV fluids, 1 liter fluid. After that, you don't give them any more fluids. You just you replace them with blood. So until now, you have seen A, B, and C. If you haven't found any problem with A, B, and C, then carry on. Okay, so you go on to D.
I wanted to add a couple of things on this. C में आपने दो चीजें बड़ी अगर तो ब्लड प्रेशर लो है, ठीक है, 90% पीपल के ब्लड प्रेशर लो होने की वजह हाइपोवोलीमिया है, या वो हेमोरेजिक शॉक में होते हैं या वो सेप्टिक शॉक में होते हैं. सेप्टिक शॉक में भी हाइपोवोलीमिया है क्योंकि वेज़ोडाइलेटेशन बहुत ज्यादा हो जाती है.
जी जी.
और जो जिस चीज से हम सबसे ज्यादा डरते हैं, एंड देन वी डू नॉट रिससिटेट द पेशेंट इफेक्टिवली, कि उसको कार्डियोजेनिक ना हो, कि हाँ जी वो कार्डियोजेनिक ना हो और हम ज्यादा फ्लूइड देके उसको और कर देंगे, ठीक है. तो 90% आपका ये सिचुएशन नहीं होगी, ठीक है. there will be 10% people, I'm just giving you a kind of a ballpark figure, लेकिन ज्यादातर लोग या सेप्टिक होंगे, इन्फेक्टेड होंगे, या हेमोरेजिक होंगे, या रोड ट्रैफिक एक्सीडेंट के होंगे, या हाइपोवोलीमिक होंगे खाना पीने की वजह से, डिहाइड्रेशन की वजह से, किसी वजह से. तो उसमें रिससिटेशन, फ्लूइड रिससिटेशन इज वेरी इंपॉर्टेंट. जो अमेरिकन अकेडमी है वो कहती है कि एटलीस्ट 20 ml पर किलोग्राम आपने रिससिटेट करना है, ठीक है, 20 ml. और अब जो नई गाइडलाइंस आई हैं वो कहते हैं आपको 30 ml पर किलोग्राम. और इसमें एक बड़ा इम्पोर्टेंट क्लिनिकल सिनेरियो, आपको एक क्लिनिकल आपको पॉइंट मिल जाता है कि if the peripheries are cold and clammy and the central pulses meaning कि आपकी कैरोटिड्स और फेमोरल, ठीक है, आपने ब्रेकियल और उसकी बात नहीं करनी, रेडियल की. कैरोटिड और फेमोरल अगर वीक और थ्रेडी हैं, वीक एंड थ्रेडी, ठीक है, तो इसका मतलब है उसको कार्डियोजेनिक शॉक हो सकता है, ठीक है. लेकिन अगर बाउंडिंग पल्सेस हैं या पेरिफ्रीज वार्म है और बाउंडिंग है, तो या वो सेप्टिक है या हाइपोवोलीमिक भी हो सकता है. उसमें एक मतलब है कि हार्ट का पल्स जो है ना, क्योंकि द फर्स्ट पल्स यू फील इज एक्चुअली नॉट द एक्चुअल ब्लड फ्लो दैट कम्स, इट्स एक्चुअली द पल्स इफेक्ट फ्रॉम द हार्ट दैट ट्रेवल्स थ्रू द वॉल ऑफ द वेसल टू द सेंट्रल. और ये सेंट्रल की बात कर रहा हूं मैं, पेरिफेरल वेसल्स की बात नहीं कर रहा. अगर कैरोटिड आपकी वार्म है और बाउंडिंग है और पेशेंट का ब्लड प्रेशर लो है, तो आपने उसको फ्लूइड देना है, चाहे वो हेमोरेजिक शॉक है, हाइपोवोलेमिक शॉक है, डिहाइड्रेशन है, सेप्टिक है, उस सब में आपने फ्लूइड देना है. और ये 90% केस यही होगा. वीक और थ्रेडी, कोल्ड एंड क्लैमी पेरिफेरीज और वीक और थ्रेडी, ये 10% में होगा. उसमें आपने फ्लूइड को जरा होल्ड करना है. उसमें आपको हार्ट साउंड भी हो सकता है, मफल्ड हो, या द कार्डियक टेम्पोनेड है, या टेंशन निमोथोरैक्स, उसमें अभी कार्डियक आउटपुट अफेक्ट हो जाती है. तो ये चीजें, दो चीजें आपने रखनी है. लेकिन 90% विल बी ऑन द सेफ साइड आप होंगे अगर आप उसको फ्लूइड रिससिटेट करेंगे, ठीक है.
थैंक यू.
नाउ बैक ओवर टू बुश.
थैंक यू. उस सूरत में आप अगर थोड़ा सा भी आपको कंसर्न है तो यू कैन गिव 250 बोलस ऑफ फ्लूइड एंड सी द रिस्पांस. तो ये जरूरी नहीं है कि आपको 1 लीटर ऑफ फ्लूइड आपने पुश करना है अंदर. तो
or one more thing, ABGs will take like almost like 20-30 minutes to come back in our system. We don't have I-stats here.
Okay.
तो वो लेना और भिजवाना और वापस आना, उसमें थोड़ा टाइम लगता है हमें यहाँ पे.
Okay, fine. Then I think you go on to fluids. You can give normal saline. You can give Hartmann solution. Recommended in trauma is Hartmann, but you can safely give normal saline 0.9%. So a liter of fluid, that's what is recommended. But Hartmann is obviously more in trauma situation. Then you go on to D and you look at patient's GCS. I'm sure you all can calculate the GCS in an unconscious patient. It's very difficult to assess the GCS level, but obviously with what is their airway, what is their verbal response, what's their motor response and eye opening. So you can calculate the GCS and then you can look at the pupils. So if you see until now, if you have noted that there was no problem with A, B, and C, then maybe the problem that they are unconscious with, maybe problem is D, could be intracranial bleed, subarachnoid hemorrhage, head injury, or if they are on warfarin, then could be an internal bleed. So you look at the pupils, pupils are equal or reactive. So now when I say pupils are equal, sometimes, people are getting concerned with a patient with GCS 15 and they talk about, oh, their pupils are slightly unequal and not reacting. So I would say pupils are the latest signs which develop after all the things happened before. So you have to have a low GCS because it's, the coning when lots of thing happened already with bleeding and coning start, then you get the pupillary response. So maybe the patient has got intracranial bleed, but they haven't developed the pupil sign as yet. So it may not be just saying okay, pupils equal reactive and there's no problem with the head. But if they are unconscious, obviously there is some underlying cause for that. So pupils, you have to still look because you will have to do the regular observations to see if what was the initial pupillary response and what happens after half an hour or when you reassess the patient. The other common causes of getting unconscious is hypoglycemia. So you can check bedside blood glucose. I think वो तो आप check कर ही सकते हैं. Bedside glucose आप check कर सकते हैं. That can make people unconscious for some, hypoglycemia, and then you can replace. So if the blood sugar is less than 4.5, I don't know what their units are there, but here, if it's like less than 3, then you've got hypoglycemia, and then you can start treating with 10% dextrose, 50 mils. Just give them a stat dose and see what's the response. You can check limb movements when you give them a painful stimulus in the center, and then you can see what's their arms doing and what their legs doing. If they have got flexion or extension, that will help you to guide your GCS. You can check the planters. They may have had a stroke, they may have had a bleed, and the planters would be up going on one side or both sides or anything. So until now, A, B, and C, and D you have assessed. If you keep that methodical approach, then you can pick up, I think, any problem in the system without knowing exactly what happened to the patient. And then we expose the patient fully when they arrive. So we just cut their clothes, put them in a gown, or just take the clothes away so that you can have a proper exposure so that you may not miss anything. So you may not need to do E at the end because everything is happening simultaneously. So the first thing that you want when the patient arrives, and if they are unconscious and you feel that they need more care or they are properly sick, just cut their clothes off. You can have a better exposure. You can attach ECG leads and all the monitoring, which you can attach to have a regular set of obs and ECG. You can look at the exposure. You can check their temperature then to make sure. And also when you expose the patient, make sure that they don't get hypothermic. So you need to cover them with something so that they may not get completely exposed and cold. So while things are happening, there are occasions when we actually cause problem in terms of like I said, if we fully expose the patient and don't cover them, then they may get hypothermia. So be careful about that and check the temperature. So once you have established all this, then I'm sure you will find what is the underlying cause. The things that would help to figure out what happened, you obviously need a collateral history. Whoever brought the patient, they will tell you what exactly happened, whether they suddenly collapsed, they fell, had a head injury, whether they were fine eating and suddenly they collapsed. So that can tell you it could be a cardiac collapse, it could be a collapse because of some sort of intracranial hemorrhage or some, there are lots of clues, but I'm not talking about any particular problem at the moment. I'm just talking about how you assess. Then when you find out what the relatives tell you, then you will have a bit more idea that what is the thing you need to concentrate more. After initial assessment, ABCDE, you will have an idea at the end that what investigations you need to request. If you figured out that there is, unconsciousness is a D problem, then obviously you will request a CT scan of the head. In elderly people, if they have had a fall, then you always include C-spine if they are above age of 65, which is recommended in NICE guidelines that you do head and neck both. Abdominal CT, if you figured out that the problem is B. Chest X-ray is mandatory, which you can do anyway because you need something on the baseline to refer it later, that how if the patient deteriorates, then at least you go a baseline, and then you have sent the bloods off. So this is how the methodical approach of ABCDE, which will help to find any life-threatening condition. And then it comes that once your ABCDE is not showing any major thing, then you can get a bit more relaxed, and then you can start reassessing from ABCD again, and then you can do like secondary survey or take a bit more history and take a bit more time to investigate. But this is to treat life-threatening emergencies. If you have found the problem, deal with that, involve the other specialties. Like if you have figured out that the airway were not patent, then you will call the intensive team and ask them to intubate the patient. Then after every intubation, you will have to do a CT scan because patient is now unconscious. Documentation comes afterwards. You document everything. I normally document in this way. A was this, B was this, C. So if you keep this approach, you will not miss anything. So document in a way so that if people are reading afterwards, so they know that you have gone through the whole systems, you have seen all these things. Like we normally write, there was, when we examine systemic examination, we say not this, no pallor, no jaundice. It's very important to write things that are not present also, because otherwise the reader would think that you may have not looked for it. So it's better to document. So clear documentation, the time of arrival of the patient, who saw the patient, and what time was it, and then how your assessment was, ABCDE, what did you figure out, what investigations you requested, and it's your responsibility to look for the blood results and the investigations. And then you've got more time to have a bit of more collaborative history about patients' past medical history, their other comorbidities, their medications, their allergies. So the history taking is obviously, you all know that you start, even if you not interested in their social life, but you still go through all the parameters, like what's the presenting complaint, what's past medical history, medication, allergies, their social life, smoking, alcohol, everything. So this is how you basically assess a very acutely ill patient, and then problem finding, solving at the same time. Once you do an intervention, go back and reassess, and then carry on. And then once the collaborative team is working, you have to have a very good interaction or communication skill with your team, that they know what they are doing. So once I know that कि वहाँ पे से system नहीं है कि आपको पहले से inform कर दिया जाए कि patient आ रहा है, तो अचानक से आता है, तो but still just step back for a few seconds and assign the roles to people. किसी एक को कहें कि आपने A देखना है और आपने B देखना है और आपने C देखना है, and you can overlook. और जो A देख रहा है तो बाकी लोग बेशक अपना काम करें, लेकिन they don't interfere, they don't talk a lot, they don't talk loud. Just let the A person talk and then tell you that I'm happy with the A, they have seen A, they have looked through the B. And then you ask the B person, okay, what is your finding? And somebody just keep writing. So that happens in the trauma situation, mostly with the trauma team. But in normal sick patients, you can also have the same approach. So nursing have got main part in this, in exposure, attaching blood pressure, cough, monitoring, ECG monitoring, all these things nurses can do. If they need drugs, they should be around. So it's a whole teamwork. And if you communicate with your team, then you can save life. So if you got any questions about it, just ask.
यार ये गाड़ी किसकी है? ये पता रखना यार किसकी गाड़ी है. तो कहना यहाँ से हटाओ. वो है ना, उसको कहना डॉक्टर फिजर आया था, दोबारा यहाँ गाड़ी नहीं खड़ी करनी. ठीक है.
Anyone else
Dr.
want to ask
you
any
have any
questions?
I think your mic is on.
I would like to ask a question. For airway, if we can see that the patient is not tolerating the oropharyngeal airway, like if the patient, the trauma patient has a GCS of 10/15 and he is not tolerating the oropharyngeal airway. So in that case, my question is, when will we go for intubation? Or
so if they are not tolerating the oropharyngeal airway, that means they are quite awake, okay? Because GCS above 8 to 15, they will be having nasopharyngeal airway. So nasopharyngeal, you can have a slightly less conscious patient like GCS of 12, 13, 10. If you insert the nasopharyngeal airway, they will be able to tolerate. And if they can't, if they are spitting that one out, they're pushing your hand away, that means that they are awake enough to not to have any airway. So you just need to have a little bit of support of their airway to keep it patent. And if they are tolerating the airway, I mean, उनको कोई होश नहीं है और कुछ पता नहीं चल रहा कि आप उनके मुंह में डाल के और आप airway अंदर डाल रहे हैं, तो it means they are quite deeply unconscious. That's why they are tolerating that. Otherwise, any awake patient would not want anything in their mouth or in their nose. So that gives you an idea. Once you start inserting the nasopharyngeal airway and it goes straight, straightforwardly. Sometimes you need both if they tolerate it, and even then their airway is, still patent, but still you can put oropharyngeal. So nasopharyngeal, oropharyngeal, both you can have at the same time. So if they are spitting it out, let them spit. It means that they are much more awake than you think.
okay.
And then once you give them a little bit of support with oxygen, then they might be, having under the influence of maybe drugs or whatever, then it means that they are not that unconscious. So oropharyngeal is much more for the deeply unconscious patients. And if they require oropharyngeal, nasopharyngeal, and you have to give them support, that means that they will need definitive airway. So you will need to work on intubation, towards intubation. So one member of your team would be calling the intensive team at that point while you are still with the patient, still going on, and you have realized that the airway is a major problem here. Patient is not maintaining their airway. So you inform them. If they come and the patient by that time becomes a bit more awake with slight resuscitation or slight help and, some sort of, alcohol तो वहाँ पे खबरतन इतनी common नहीं है, लेकिन यहाँ पे sometimes they are under the influence of some medication or drugs. By the time they improve, when you reassess, they might have improved. So you may not need the definitive airway as well. So that's why reassessment is also very important. If they come unconscious, you starting with the oropharyngeal, nasopharyngeal, by the time you reach to D, they start throwing things away. That means that they're waking up. So you reassess and say, okay, well, that's fine. Take the nasopharyngeal out, take the oropharyngeal out. They're not tolerating. So maybe the airway is getting better. So they may not be the case that they always deteriorate, but they may get better. So you may not need more interventions. Does that answer your question?
Yes.
I have a question for the SMOs. When would you use a cervical collar on a patient? Or do log rolling and all that stuff to save the spine, cervical spine? Hassan?
sorry, sir. Actually, I have a patient with me as well, along with this. So, sir, when will we do patient log rolling?
Log
Or
rolling or cervical?
When you immobilize them with cervical spine immobility, like three-way collar, or
when would you suspect a cervical injury?
Sir, RTA की injury होती है या if there is any injury where patient cervical neck or if there is a spinal injury, we do log rolling of the patient. We do not try to mobilize the patient a lot. मतलब उसके head और cervical जो है spine को ज़्यादा mobilize नहीं करना चाहेंगे. That's when we do log rolling in
तो हम लोग अगर पेशेंट आपका जो है वो डीपली अनकॉन्शियस है एंड यू डोंट हैव इनफ हिस्ट्री, so the safer thing is to immobilize them, considering that they may have had a trauma. Even falling from their own height in an elderly patient especially is called silver trauma, and you can't have a collateral history, then yes, you need to immobilize their spine. So you keep the spine in line, you put the blocks around their head and tape around from the chin to the forehead, so that collars are now no more recommended. So you just have to have the blocks around their head. So you immobilize, and then obviously you have to investigate further if they can't tell that whether they've got pain in the neck or not. If you have got a clear history that this person was sitting on the sofa and he was talking to me watching TV and suddenly he collapsed, then my threshold would be low to immobilize the spine, because you know that there was no injury to the spine. So you carry on with, obviously they are unconscious, so there may be the cause is something else, not the trauma. But if you are not sure, if the history is not clear, if the patient cannot tell you what happened, or the paramedics or whoever brought the patient, like if somebody is found on the street collapsed, then yes, I would immobilize the patient. So when there is nothing known, immobilize. If you got a clear history with an eyewitness that he was sitting and collapsed, even if you are standing, if you imagine a 60 or 75-year-old gentleman standing and he fell, like collapsed on the floor, so you suspect a head injury, and the head injury with a cervical spine injury. So even falling from the height, you can have lots of serious injuries with rib fractures and flail chest, and especially elderly people. So yes, you do immobilize in that case.
Bushra, do we have to do 5H and 5Ts?
No, this is I am talking about the assessment of the patient. My next session would be on adult life support, when your patient is unconscious and has got no pulse. So that is a totally different scenario. In this case, we had all the parameters. This was our initial approach towards the sick patient. So we will talk about only the assessment bits of the patient. And this methodical approach you can apply on even awake patient, even in any assessment that you do. But yes, of course, more in slightly unconscious patient. But when you look at the patient and if they're not breathing and there's no pulse, then we'll move on to the algorithm, which is advanced life support. So we will talk about that in the next session. We will, that's the whole session of that, when patient is unconscious and they've got no pulse. So we will talk about that. That is next topic about advanced life support. So this was the initial assessment. So I don't know when the patient comes in your department, how many people are there to receive an acutely unwell patient?
I would like to talk about it. Like today, I had 12-hour day shift duty. So at a time, we have 2 emergency medical officers, like me and my colleague, and 2 staff nurses available in the ED.
Okay.
And if we think necessary, we can call the SMO on duty. And the SMO is usually in the wards. And there is 1 medicine SMO and 1 surgery SMO.
Okay. So
like today on Sunday.
This is going to change a little bit. We are trying to get 1 SMO and 1 medical officer in the ER at all times. So hopefully that will happen very soon. There will be one SMO in the ER and there will be one SMO in the wards at all times, 24/7. So you'll have 2 senior medical officers available. Okay.
So 3 people are, I think, enough to see an acutely unwell patient to begin with. One is just overlooking and telling what to do. The other person, A, and the nurse can do the B and C, or, the A person can do A and B together. And nurses should be able to cannulate, do the, bloods, and you can intervene to assess their abdomen. And if you got more staff, then obviously you need a dedicated person for B. But you can do all this assessment on your own. And if you find that there is a problem with A, that means that you have got more, you need more staff. And then you just alert the people that you need help. Because for airway, then obviously you might find a bit further things down the line. So if you have found the problem in A, starting the initial assessment, then you call for help, call more people early. It's always easy to send people away that, sorry, that's fine, we don't need you anymore. Rather than when you reach to C and realize that, oh, ये तो बहुत बड़ा problem हो गया, now call, और उनको भी तो फिर आने में time लगता है ना, तो it's better to have help early rather than a little bit later के बाद में देखेंगे. If they come and you have already assessed the patient and you don't find any problem, just say thank you very much, we are fine, we don't need your help anymore. So it's easy to do that, rather than reaching to D and say, oh my God, I need more hands. So by that time, you will lose the opportunity to treat the life-threatening thing. So I know it's difficult when the patient arrives because mostly relatives bring the patient, not the paramedics, but there should be a culture that if paramedics are bringing somebody in the ambulance, they should be able to call the emergency department before coming, that what are they bringing, so that you are ready for whatever the equipment required staff that you need. That if somebody is bringing, oh, I've got a patient who's unconscious, and we are bringing and we are reaching in about 10-15 minutes. So those 10-15 minutes, is a huge time for you to set up everything, delegate the tasks, get all the things ready, and just be there, stand by when your patient arrives, rather than just somebody pouring in and bringing and dumping a patient onto the trolley and ask you to come and see the patient. So triaging that's why important. The nurses see the patient and they will tell you that, oh, this patient needs a priority, this one is not a priority. So that priority is also on the base of ABCDE.
Any other questions for Dr. Suhail?
Okay, so okay. I think
we'll just decide the next topic and
the next topic. On the next weekend, I'm actually working, but I can do a little bit earlier. I'm working at 4 o'clock, which is when we started the session. So I can do 2 hours early.
7 o'clock.
7 p.m.
I mean 7
p.m. Would that suit people? Even Saturday or Sunday, both. I've got working Friday, Saturday, Sunday. So I will not be available at this time.
Okay, would that be doable?
7 o'clock, yeah. 7 o'clock Pakistan time on Sunday. Let's do Sunday.
So, inshallah.
So we will. And I will send you. Okay, I will send you the algorithm for advanced life support, which would be in the case when you realized on the A that there is a big problem and patient is unconscious and they're not breathing and they haven't got any pulse. So you have to resuscitate them by doing CPR and stuff. So this is a more serious scenario. So the algorithm that you follow, we will talk about that. I'll send you a snapshot picture on WhatsApp. Have a look. You can zoom in and see. And then we will discuss that. And I think it would be good to see more people, more faces, and more interaction, so that it feels more engaging, so that people are getting what I'm not just bombarding the whole information into you, but you just feel more interactive. Would that be okay?
Okay, I think everybody should be able to at least review the subject at hand, and then write questions, whatever questions you may have, and we can actually go through the algorithm maybe in like 10 minutes, no more than 10-15 minutes, and then the rest would be question answers and
more discussion,
removing misconceptions. Yeah.
So in this week, if you start applying this approach in ABCDE and see if that helps, and you will find the difference. So as soon as you start learning things, just start applying things. You got a week now. From now on, you have learned now. You don't need to read the whole thing that I have sent. I have mainly elaborated everything in that. So try and use this approach from tomorrow when you are at work and see if that helps. And then, we will talk about it. If you have any further questions, we can still discuss on next Sunday.
Thank you very much, Dr. Suhail, for
okay.
giving us the opportunity to read through it. And thank you for all the participants who have attended the class. And please spread the word that this is something that is very valuable for the senior medical officers and the medical officers, and they can actually have a lot of their confusions removed and resolved through this. Okay. And it's a big opportunity, and it will be available on the website. We will send you a link that you can review it later on if you have any questions. Okay.
Thank you very much. Have a good weekend, and we'll see you inshallah next Sunday.
Okay.
Allah Hafiz.
Assalamu alaikum. Allah Hafiz.